نقدر نخليها بالمحاضرة، بس تقريبا كل المعلومات المطلوبة موجودة بالمحاضرة. And now today, radiology of the gastrointestinal tract. The objective of this lecture is to know the basic principle of the GIT imaging with different modalities that use in this system, overview the different radiological terms and finding regarding the different parts of GIT system, which base imaging modality used for specific pathology. So the question, what about the type of the modality now used for this system? شنو تعرفون الموداليتي اللي احنا بنستخدمها حاليا؟
Ultrasound.
Endoscope, regarding what other type? Barium. It is commonly used now?
No.
No.
Blind
But you want to
X-ray.
have information by
X-ray, blind.
what the type of the X-ray?
Blind.
X-ray? In which case?
Intestinal.
By
CT.
CT now to have a gradual. Ultrasound sometimes used in some cases. Good for this case. 40-year-old male present with the emergency department with a engaged history of the gastric pain, nausea, and vomiting. The pain is described as burning in nature and intensified after eating. Although the patient have intermittent episodes of similar pain over the past few months, the episode is notably now more severe and persistent, and the patient have history of the osteoarthritis. On physical examination, the patient appeared mildly distressed. And approach to this case we'll discuss at the end of the lecture. طبعا كل كلمة موجودة في هذه الكيس هي لها معنى، يعني ما محطوطة المعلومات هيجي. So, the gastrointestinal disorder diagnosed by endoscopy and imaging. Why we prefer the use of the endoscopy for the upper GIT? Information because the mucosal line directly on the allow biopsy material. The disease of the esophagus and gastric region, the endoscopy is applicable and you can do direct visualization and the biopsy can be taken. Beyond the endoscopy, the imaging can be used in the bowel, including plain X-ray, whether it is supine, erect, decubitus, or contrast, including barium and water-soluble material, CT, the native CT, contrast CT, CT pneumocolon, and virtual colonoscopy. MRI not routinely used, but it have now rule for the staging, for the patient have inflammatory bowel disease, and this is a new fluorodeoxyglucose post-roll imaging, sometimes used for the distant metastasis. Sometimes we can use ultrasound and angiography. So now we talk about the contrast. We have two types of the contrast needed. We have barium, used in the barium material, and also we have water-soluble contrast. What the benefit and disadvantage of the barium? The barium produces excellent opacification of the mucosa, good coating, and it is inert. But the disadvantage, barium may solidify and impaction proximal to the structure. So if the patient is suspected to have bowel structure, barium not used. And also irritant when there is a suspicion of leakage or there is a rupture in some part of the bowel. And no need to be used in with CT. While water-soluble contrast media in patients suspected perforation and leakage prior to the CT examination, pediatric age group, small bowel obstruction to confirm the site of the suspected large bowel obstruction. But the disadvantage of the gastrography, it is rapidly diluted, irritant if it is passing to the lung, and it is less radio opaque. What the type of the contrast media used in CT? contrast. كده شنو راح يكون؟ oral or IP. Single contrast examination, the lumen is filled by barium suspension only. It is used for peristalsis, emptying, pathological changes such as stenosis, dilatation, luminal film defect, as polyp, and compression from outside. While double contrast, they use barium with gas-producing crystal, the inner surface coated with the contrast material. It is allow the date visualization of the mucosa, which is detection of the inflammatory adenopathy. If we look for these images, this is called single contrast, only the barium. While there is air and barium, it is called double contrast. This is the barium swallow. This is the esophagus. This is a segment of the bowel with diverticulosis, double contrast, air and barium, and this is only single, and there is a single contrast with film defect. What's the role of the computed tomography? We can use both oral and intravenous contrast media. In case of the arterial portal and delayed phase, GIT tumor diagnosis staging, sometimes appendicitis, obstruction trauma. It is a multi-format images, and we can use oral gastrography. The benefit to show the thickening of the bowel loop as an inflammatory bowel disease, lymphoma, TB, masses, fatty stranding, complication, and distant lesion. This is all over the barium site. This is a CT scan of the abdomen with contrast. There is any evidence of the oral contrast or not? هذا شنو؟ Contrast within the bowel. What about this? Contrast within the bowel. This is called virtual colonoscopy, and this is a polyp, similar to the endoscopical finding. This is called pneumocolon, that the colon filled with air, then subtraction of the imaging made to produce this is a study. It is called pneumocolon by CT. Another imaging modality can be used, including endoscopical ultrasound to assess the bowel wall thickening, depth of the tumor invasion. If we look for this picture, there is a mass in the bowel, and this is increased wall thickness. Ultrasound also can be used in which cases أكثر شيء نستخدم appendicitis. Also can be used in hypertrophic pyloric stenosis, intussusception, anything. And this is the picture of the MRI for the colorectal fossa, depiction of the any lesion, and there is evidence of the bowel wall thickening, and patient have some sort of inflammatory bowel disease. The nuclear medicine, as you know, sometimes used for the emptying, for the distant metastasis, not routinely used. Now we talk about the radiological term used in this system. We have a mucosal pattern, whether it is normal or abnormal, and filling defect, structure, and ulceration. المقصود بهذه الكلمات اللي هي انه احنا شلون نقدر نعبر عن هذا الباثولوجي اللي موجود في السيستم على هذا الترم, whether it is normal mucosal pattern or abnormal, there is any filling defect, ulceration, and structure. Barium swallow for the esophagus, barium meal for the stomach, barium follow through for small intestine, and barium enema for large intestine. The mucosal pattern. If we look for the other upper images, mucosal pattern, normal mucosa of the stomach and the small bowel are thrown into the fold that exaggerated by peristalsis. If you look, this is a single or double contrast. Single. What about this?
Double.
Double. The mucosa visualized by which one? By the double. It is a longitudinal, or you know what we call this? Gastric root. And this is the hostra of the large bowel. And this is small bowel follow through. Small bowel follow through. And this is the mucosa. It is a bulbily conventive. What the About ulceration. Ulceration is the breach in the mucosal surfaces by the varium fulviculator. If you look for this picture, this is stomach, and this is the cavity filled by varium, and this is a defect in the mucosa, and there's a collection of the contrast here. And this is the typical appearance of the gastric ulcer. Collection of the varium at this surface. And this is a normal picture of the gastric. Filling defect. Filling defect is any process that prevents the normal filling of the lumen. Could be intraluminal as the food which are surrounded completely by varium. Why? Just a mass dilution inside the lumen. The food is stick to the wall or movable. Because it's surrounded by varium. Intramural filling defect, something related to the wall, as in the carcinoma, leiomyoma, indentation on the lumen, and are not completely surrounded by varium. This is not surrounded by varium. Or there is extraluminal filling defect. There is a compression produced by something mass or outside the lumen, enlarged pancreas, lymph node, or any mass produced. If we look for this picture, there is any filling defect?
Yes.
What you suggest? This is from out or from in?
Out.
Out. Okay. There is any filling defect? The stomach filled by large filling defect. All of these are filling defect. Intraluminal. What about this? Filling defect surrounded by?
Contrast.
What about this? Filling defect. What about this?
Filling defect.
Filling defect. And what about this? Also, there is a filling. Structure. It is a circumferential narrowing. It should be constant. As you know, the varium study, the patient movable during examination. And peristalsis, if there is a narrowing or structure related to the peristalsis, it is transient. But there is a constant structure indicating pathology. So the feature of the structure, it is most important, whether it is tapered and or there is overhanging shouldering. Shouldering indicating what? Indicating malignancy. If we look for this is a small, smooth filling defect, narrowing or structure. What about this? Overhanging edge. So, this is a smooth or shouldered edge. You know this case? What about this case? Echinacea. What about this narrowing and structure? It is regular?
No.
Shouldering? What about this? Regular or not?
No.
Irregular. Irregularity of this structure indicating something suspicious. And what like here related to the carcinoma. So now we talk about the contrast study and the varium. The indication for the varium is all written here. Okay. The most important one is this page here. There is any rule for the plain film for the pathology of the esophagus? There is any rule؟ عادة لأنه إحنا البيشنت شاكين عنده مشكلة بالإيزوفيغاس. أكثر شيء شو نسوي له؟ شو نسوي له؟ يعني هو شلون يوصل للفيروس؟ لازم نسوي له شنو؟ اندوسكوب. وبعدين ممكن عندنا السي تي والإمجي. أوكي؟ بس هذه بلين فم شنو الرول؟ وات ذا about the plane film. إذا أجاكم طفل في اليوم للطوارئ.
فورم.
إذا أجاكم طفل للطوارئ رأسا قالت لك أمها إنه هو رأسا اختنق. رأسا ما يقدر يتنفس. أكثر شيء بالأطفال إيش تتوقع؟ هو الفورن بادي. وإذا رأيت إذا مختلف عليكم السلام. شلون يكون بالتقامس؟ شوف هذا كذا إلى العين. فالفورن بدي إذا توقعناه فورن بدي باللاين أو إذا توقعناه بالإيزوفيغاس شلون راح أشوفه؟ إذا البيشنت إجا تشوكينج إيش تتوقع هذا؟ بالتراكيال وبالإيزوفيغاس؟ وتاخذ له لاترال صحيح حتى تشوف انه بس هو اكيد اكو واحد بالإيزوفيغاس عاده يكون ستيبل بينما اذا كان بالتراكيال شبيه عارفون؟ فهنا اللي احنا بدنا نشوفه هذا هو هذا فورن بدي وهذا فورن بدي another indication for the brain extra for the angiogram rather than it is displaced. This is displaced or not? وين رايح؟ هنا هذا normal. So the barium study, this is a smooth 3 to 4 fold by the double contrast, and this is a normal texture of the esophagus. What about this? This is called tertiary contraction of the stomach in the elderly. It's testicular. تشوفوا؟ هذا هو transient ممكن يكون وعادة يكون بالelderly without symptoms. Sometimes the patient feeling dysphagia. The structure of the esophagus, we have a lot of the cases. The one of the important thing to know in the structure of the esophagus, the location, the outline, the length, and the associated masses. So, البيبتيك structure شو تتوقع وين راح يكون الستركشر؟ lower, يعني هو راح يصير reflect from the gastric to the lower part of the esophagus. The character of this structure is smooth, short, and tapered end, but sometimes patients have long and extending up in the middle part of the esophagus, but it is smooth in the outline. The achalasia is similar to the rat tail appearance. It is a neuromuscular abnormality resulting from the failure of the relaxation of the distal part of the esophagus. It has smooth tapered end, if you look for this. Many patients with this achalasia may have another abnormality related to the aspiration, so the patient may have consolidation and bronchiectasis related to the aspiration. This is corrosive structure. What's the meaning of the corrosive structure? Ingestion of the alkaline or it is long, irregular type of structure. This is a long or short type of structure? Long type of the structure, and it is irregular. Sometimes we have structure related to the filling defect from the outside or from the wall. If you look for this is a filling defect, and there is a narrowing or structure of the esophagus, only this part. And there is compression from the outside related to the aberrant right subclavian artery. It is arising from the other side. The most important thing is the esophageal carcinoma. What about structure, type of structure? Regular, shouldering, filling defect, associated with the filling defect, and structure. What about this, Chichi? All of these mass. Filling the esophagus, and this is a mass filling the esophagus by the transverse view indicating a tumor of esophagus. The role of the CT is to detect the mass, surrounding tissue, distant metastasis, all of these can. Another finding, we have the mucosal pattern, and then we have structure, then we have dilatation. Dilatation أكيد إنه بريستينوتيك سيجمنت شو راح يصير بيه؟ dilated اللي هي أكثر مثال نقدر نشوفها من هو الأكليشن. هنا أكو dilatation or not؟ أكو dilatation. اللي هو obstructive type. Sometimes we have case non-obstructive type of the dilatation of those patients scleroderma. Scleroderma is a dermatological disease, so that usually dilated esophagus associated with the sclerosis in the finger, if you look for these cases. Dilatation of the esophagus, sclerosis. Esophageal web is a shelf-like structure inside the esophagus, one of the abnormality not usually done. If we look for this, is more common is a Zinger diverticulum or it is a pouch. يعني بالضبط مثل الجيب يطلع by CT. This is the esophagus and this is the Zinger diverticulum. يعني accumulation of the food inside this pouch. Patient may have aspiration, then complication of the lung. Regarding the esophageal atresia, it is a congenital anomaly and we have multiple types of the defect. This is beyond you, but just to mention it, this is a picture that the patient have history of the variome study and the variome on the esophagus and trachea. This is indicating a tract or fistula between both the esophagus and trachea. عادة المفروض هو ما يسوي هذا الكونتراست ستدي، يعني مثل ما في الجراحات الثانية، يعني هو عادة إذا أكو blind esophagus by tube, just. Another film defect in the esophagus it is related to the tumor as leiomyoma or sometimes related to the food varices in patients with portal hypertension. This is multiple film defect. And we have some patients have esophageal candidiasis. اللي هو راح يكون شاقي appearance. Look for this blanket and look for the appearance of the esophagus. يشبه لو ما يشبه اللي هو هذا كان tiny filling defect in the esophagus. اكو سؤال لحد هنا؟ طبعا يرجون نطلع الساعة أنا شوي دا أمشي سريع لأن الساعة ما شاء الله راح يجينا حضور كل 9:30 لأن في امتحان. Regarding the esophagus, as you know, we have variome study and we have contrast study. Regarding the indication, there is a lot of indication and there is indication for the imaging modality. This is the stomach and this is the gastric groove. This is a normal gastric groove. And this is a normal fold, normal, continuous, no filling defect. And this is a single contrast study of the by CT. This is a stomach filled by contrast, thin wall, no thickening, no mass protruding to the lumen. And this is the stomach filled by air. And also there are no wall thickening, no mass, no pitch. Regarding the most common phase and considered as emergent case اللي شنو راح يكون peptic ulcer. The peptic ulcer could be benign and gastric ulcer could be benign and malignant, while the duodenal ulcer almost always benign. So the appearance of the gastric ulcer, either it is in face or in profile. If you look for this is a breach in the mucosa and there's a collection of the contrast material here. While this, also there is a collection of the material, contrast material, and this is a ulcer crater collected with contrast. This is the table show the appearance of the ulcer, whether it is benign or malignant. Smooth ulcer, tapering age, ulcer projected beyond the lumen, radiating fold extending to the crater, depth of the ulcer greater than the width and Hampton line. While in the malignant eccentric location within the lumen, and irregular shouldering cone reaching to the greater. Look for this picture. Look for this. This is the fold radiating to the ulcer, reaching the ulcer crater or not. مفهومة هاي النقطة ولا لا؟ لأن هذه مهمة. إذا هذه الفولد واصل للألسر greater something benign. If it is not, if you look for this fold reaching to the ulcer crater or interrupted. interrupted indicating malignant lesion. Also, the same with the esophagus, we have multiple filling defect in the stomach, carcinoma, polyp, food, blood, bizarres, drugs, and gastrointestinal gestational tumor. If you look for this, there is any filling defect? What about this? شو تتوقع من هذه؟ Multiple filling defect ويعمل اي شيء؟ Multiple polyps. Large polyps. What about this filling defect? It's a large filling defect. سامعين بذول البيشنت اللي just different materials مثلا hair, plastic materials اللي هم ذول تقريبا psychological person ذول اللي هم للأوتيزم suggestion of the material, whatever type of the material. أكثر شيء لقوا إن هم ممكن suggestion of the collection of the hair inside the stomach and produce large filling defect. We have, this is the stomach, and what about this? Soft tissue mass, protruded part of this inside the lumen and most of the part outside or inside outside. What about this? There's mass. What about this mass? Protruded inside the lumen? Inside the lumen. And also we have another mass here. All of these are tumor, whether regard just a tumor or we have gastrointestinal and insulinoma. And a part of this gastrointestinal and insulinoma regarding a lot of the enzyme and patient presented with peptic ulceration in most cases. The carcinoma. The appearance of the carcinoma in the stomach have variable appearance. If you look, maybe you have irregular filling defect or just malignant ulcer, or patient have linotyplastica, diffuse wall thickening, or sometimes you have pseudoepipelagia appearance. By CT, you can staging, characterization, detect the abnormality, invasion, and lymph node. If you look for this patient, this is the stomach, there is any filling defect or not? Filling defect, all of these multiple irregular shape filling. What about this lesion? Just diffuse circumferential wall thickening. دائما circumferential diffuse wall thickening and uniform ويعمل يمشي ويا الليمفوما. تعرفون one of the commonest type of the lymphoma in GIT is the stomach. Diffuse wall thickening. What about this irregular thickening? Gastric tumor. Sometimes the patient have gastric outlet obstruction. You look for this. This is a gastric outlet obstruction by variable studies, neuro, even totally blocked. This is the case of the hypertrophic biliary stenosis by ultrasound. شو ممكن تجينا هذا البيشنت؟ لا قبل الست اشهر هو راح تبين شو يجي كلينيكلي بروجكتايل فوميتنج حتى مرات خلال الفحص انت تشوفه وتؤثر ذا بايلوريك كانال. عادة نستخدم الالتراساوند او مرات تجي كلينيكلي. سامعين هذه الاوليف لايك in the upper part of the abdomen يعني palpable mass by clinical examination. Hiatus hernia. We have two types of the hernia. Herniation of the stomach to the mediastinum. We have sliding and rolling type. The sliding type is most common type, the gastroesophageal junction and part of the stomach situated above the diaphragm. Sphincter incontinence to the reflex causing esophageal ulceration and peptic. هو هذا اللي يهمني من الموضوع أنا. يعني هو صار أوكي هو صار عنده هرنيا كذا شو اللي يهمني؟ إنه هي راح تكون ريلاكس هذه راح يكون acidic material ascend to the esophagus and produce peptic. If you look for this, it's all of these parts. While paraesophageal, that the gastroesophageal junction is at its location, but the part of the stomach out to the stomach. And this is the part. The duodenum, we have two pathology in the human duodenum. Most common is it? This is what this? Collection of the barium in this part. شنو اللي موجود؟ شنو هذه؟
ulcer,
Ulcer. Usually benign or malignant. And also we have diverticular incidental finding. If you look for this is a collection of the barium outside the wall of the duodenum. This is a diverticulum. By CT, this is a diverticulum. So, I think we have the two last. Endoscopy in the small intestine is also done or beyond. In the small intestine endoscopy أكثر شيء terminal ileum شو وصل للterminal ileum اللي تجينا عادة نقدر ناخذ عادة راح نستخدم الايمجنج موداليتي أكثر مما نستخدم شنو؟ الاندوسكوبي. Barium follow through, and we have 300 ml of the barium X-ray interval as يعني حالها حال أي أشعة or enteroclides by passing the tube, reaching inside the bowel and followed by contrast. The normal mucosa of the small intestine, this is a normal mucosa of the small intestine, and similar to this, it is called biliary appearance. As you know, how we know that this is a small intestine rather than large intestine? Central, بعد
volvular
volvular conventus, to transverse vault of the small intestine projected to the lumen. After filling of the bowel by contrast material, this is volvular conventus or the transverse vault appear as filling defect. اللي هي هذه اللي موجودة. You look for this. بس هذه visceral or volvular conventus. شلون أعرفها؟ Tiny. Taking the whole middle of the bowel and the location of the bowel within the central part of the duodenum. All of this. So in summary, our GIT endoscopy is gold modality for the upper part of this as esophagus and the stomach. Different imaging modalities used for structure beyond the endoscopy. Still we can use barium study, but in little case, intravenous contrast media used with the CT is better. CT have the advantage for diagnosis, pathology, surrounding tissue. Peptic ulcer, whether it is benign or malignant, duodenal ulcer usually benign. Gastric tumor have different radiological appearance. Pathology of the GIT system results in the form of the abnormal mucosal pattern, ulcer, filling defect, narrowing, and dilatation. تذكرون الكيس اللي حكيناها بالبداية؟ شنو تتوقعوها؟ شو تكون هذه؟ شنو هي كانت؟
ترى vertical
اللي هو البيشنت جاي بيبتيك ألسر. شو نسوي احنا عادة هسه بالبيبتيك ألسر؟ اندوسكوبي مبدئيا. إذا شكينا بكل شيء لازم ناخذ بايوبسي بس يعتبر هو شيء. إذا احنا سوينا سي تي ان كيسز اوف ذا بيبتيك ألسر شنو اللي راح نستفاد من العلاج؟ شنو راح يسوي؟ إذا هي كانت كارسينوما، إذا هي بناين ممكن يفيدني السي تي؟ ممكن إذا كانت perforated peptic ulcer راح يصير extravasation of contrast material inside the abdominal cavity. يلا أوراق وأقلام.